Just before we move on to our next section, I would just like to remind everyone, one of our collaborators today is Anticoagulation in Practice, and just remind everyone that the stall is out just in by the door there, so don't rush straight out to the coffee. Make sure you visit that stall as well. Okay, so we're now moving on to how we prevent hospital-acquired thrombosis, because clearly with the devolved nations, the way that we're running hospital-acquired thrombosis prevention strategies is different in different places. Now, I think the principles are very much the same, but it gives us an opportunity to share good practice and learn from each other. So what I thought might be helpful is the people who are giving their accounts, if you all want to come up now, and then we will have presentations, and then we will have a discussion after. So what I'm going to do, as I'm chairing this, but also be presenting a little later, I'm going to start with Professor Beverly Hunt, who, whilst you may feel that she needs no introduction, what I would just like to do is pay tribute to her tireless campaigning on behalf of patients and the work that she's done with Lifeblood. But not just the work she's done in Lifeblood, but also the way that she has a very adept skill at encouraging and inspiring other people to take on these roles as well. I certainly wouldn't have my academic career if it wasn't for Beverly's support at the beginning. And she's incredibly humble, but crumbs, I wouldn't want to cross her. Beverly, over to you.
So I'm not actually going to present my own slides. I'm going to present those of Helen Morrison, who's the programme manager for NHS England as far as the prevention of venous thromboembolism is concerned. She's really sorry she can't be here today, but these slides really summarise where NHS England is in preventing hospital-acquired clots. And I want you to have a look and see what we're doing. This is a world-class system. NHS England leads the world in the prevention of blood clots in hospital, and you'll see why. So we know that if you go into hospital, you are at risk of venous thromboembolism. Whether you walk in with your bag and you go to a medical ward and you have drugs, or you go to a surgical ward and you have an operation. And in fact, actually, it's the risk of going to the medical ward that causes more blood clots than the surgical patients, because there are many more patients going to the medical wards. We know that these blood clots lead to a substantial cost personally, death, and suffering. And we now know from the work of Professor Kakar and his father that if we give blood thinners, we've known this for many, many years, we will reduce the death rate due to hospital-acquired clots. So about 10 years ago, we set out to ensure that prevention of venous thromboembolism is the standard of care if you come into hospital. It's an NHS priority. So it's been a very long journey, and Lifeblood was founded in 2002, and we very quickly became aware that in the UK there was poor prevention of blood clots from hospital admission. So years ago, in 2004, Professor Kakar and I had a lunchtime meeting over sandwiches with some of the members of the Health Select Committee across the river in the Houses of Parliament. And we told them how poor prevention of blood clots in hospital was. They were appalled. And they set up an emergency Health Select Committee to look at the problems of venous thromboembolism in the UK. And that was published in 2005. There was an enormous amount of press response, and they recommended that NHS England and NHS Scotland Wales and Northern Ireland set up systems to make sure that if someone came into hospital, they were risk assessed for their risk of having a blood clot, and they got appropriate prevention, stockings, blood thinners, pneumatic compression. And we campaigned on. 2006, Tony Blair was Prime Minister. There was actually a question in the House of Commons about when was prevention going to be implemented. And NICE started taking interest. They produced some guidelines for surgical patients in 2007. But it really wasn't until 2009 that there was a really profound, concerted effort to say to NHS England, would you please do something? It was a combination of health professionals, it was the all-party parliamentary thrombosis group, working with Lifeblood. The three of us, we pushed. We weren't pushing against an open door by any means. And we all went to a meeting, which was a summit on venous thromboembolism in 2009. And Sir Bruce Keogh, who's the medical director of the NHS, stood up at the end and he said, well, this is already very good, but we couldn't possibly introduce another target. We don't need any more targets in the NHS, so I hear what you say, but we'll just have to try and persuade people to use prevention of venous thromboembolism. And I was sitting next to Professor John Black, who at the time was the president of the Royal College of Surgeons, and nudged him and said, come on, you can't let him get away with this. So he stood up and said, actually, we want the target. We, the surgeons, the health professionals, we want you to introduce a target. So in 2010, we got something called the sequin target. Now, the sequin target, we don't need to know what sequin means, but it basically meant that if you went into hospital in England, if you didn't get risk assessed, if 90% of the admissions weren't risk assessed for the risk of venous thromboembolism, then the hospital paid a penalty, a financial penalty, which was 1% of its budget. Now, in any system, money talks, and so the hospitals rose to the challenge, and we now have a situation where each hospital has to report back to a central body to show that all the patients are being risk assessed. The target was moved up, it's now 95% risk assessment. So if you go into hospital, you will be risk assessed, and there should be protocols in place to make sure you get appropriate thromboprophylaxis. And at the same time as this was happening, we also had guidelines developed by NICE so that we could know which patients received appropriate thromboprophylaxis. This took a huge amount of energy from all of the groups, but we got there. So really, I've summarised that. So what do we have in place in NHS England to make sure that this keeps happening, to make sure that prevention of blood clots remains high on the healthcare agenda? It's the number one patient safety issue. It's much more important, it's a much bigger cause of death than hospital-acquired infection or any of the other issues. So what have we got in place? Well, we've got the guidelines in place for the doctors to use and for each hospital to produce their own local guidelines based on the NICE guidelines. We have a national, what we call risk assessment tool, so we all have to ask the patients the same questions about their risk. And then every hospital has to supply centrally all the data on their risk assessment. We've got the financial incentive in place. It's now changed. The financial incentive changed in April, and if you don't hit 95% risk assessment in England, then for every patient that you miss, you have to pay a £200 fine. So still very high in the manager's mind, we need to get risk assessment going. And then the other thing that NHS England is trying to do, because of the strange system we have, where we have commissioners purchasing services from hospitals, is to make sure the commissioners are aware of this system in place, to make them aware that without prevention in hospitals, we would have a higher death rate. So what this lingo says, it says VTE has been firmly embedded in the safety and quality agenda. So now within NHS England, it's been reorganised yet again, and it comes under patient safety, where it should sit, which is called Domain 5, and it remains a priority area in delivery of hospital care. So here we've got the summary of what has actually been happening. So in 2010, we've got the data on the percentage of patients who are admitted to hospital who are risk assessed. And you can see it started pretty low. And over time, by 2012, 90% are actually being risk assessed. And you can see since that time, we have achieved very good levels of risk assessment. So NHS England is working. If you go into hospital, you will be assessed for your risk of venous thromboembolism. And if you look at all the contractual work that exists between NHS England and the hospitals, it's actually in the contract. So it says you have got to do this, and if you don't do this, you'll be paying a financial fine. So this is what it actually says. And not only now do we ask for risk assessment, but we're also asking for root cause analysis. So what do we mean by that? We mean if somebody does have a clot, either in hospital or 90 days afterwards, which is the definition of hospital-acquired clot, then someone has to sit down and look at the data and say, was this preventable? Was there a problem here with the way thromboprophylaxis was given? Because if we give prevention, we know that we will reduce the rate of clot. So if you have surgery and you get thromboprophylaxis, you will reduce the rate by about 60%. For medical patients, by using blood thinners, we're reducing the rate by about 50%. So some people will still, unfortunately, even with best practice, go on and get a clot. But in some cases, if things aren't quite right, if not the wrong dose of blood thinners is given, or maybe they forget to give them for whatever reason, they will have a root cause analysis, and the hospital will learn from what has actually gone on and be able to say, okay, so there was a problem in this case, we need to address this particular department and make sure this doesn't happen again. And then the last thing that's happened is that NICE set what they call quality standards. So they say that each hospital in NHS England must hit certain levels of certain standards of care. And these are the standards of care for venous thromboembolism. So when a patient is admitted, they must be risk assessed for their risk of clots and bleeding. They must be given verbal and written information. They must, if they actually require stockings, have them fitted properly and monitored, taken off every day, skin checked underneath. They need to be reassessed again within 24 hours and offered appropriate thromboprophylaxis according to the guidelines. And then when they go home, because most of the hospital-acquired clots happen when they go home, they need a leaflet, just a few words to say, when you go home, remember you're at risk of clots. And if you get any of these symptoms, please present yourself back to a doctor or health professional. And lastly, for those patient groups where we now give what we call extended thromboprophylaxis, so the operation itself is so risky that they need to take blood thinners at home, as hip and knee replacement, or if you have cancer and you have operation, that they actually do receive it. And measures are in place to make sure it happens efficiently. And then the other thing that NHS England do is they have NHS Choices website, and if you go on there, there is quite a lot of information about blood clots, what actually blood clots are, and what's happening in hospital, and a little bit of what I've said already. So just picking up on what was said earlier by Ian, I think we all recognise that there are issues with medical education around blood clots. We're very aware that some people don't get diagnosed as quickly as they could. So we need ongoing education. So there's a number of e-learning modules coming out. Lifeblood itself offers a day for medical students, teaching them about basic haematology, including venous thromboembolism. So we have this amazing system in place, and this doesn't happen anywhere else in the world. So let's actually have a look at the outcomes. Does this actually change things? So we've got some data from King's showing that at King's College Hospital, this is a paper they published, there was a reduced rate of blood clots after they introduced these measures. But at a national level, we're very good in England at auditing what happens at death. We look at all the death certificates. We can look at the rates of blood clots that occur and are admitted back to hospital. We now have 2 papers that show that there's actually a reduction in mortality in the national death rate due to pulmonary embolism. So the first paper showed that in those hospitals where they got 90% risk assessment, there was a 15% reduction in the rate of venous thromboembolism locally. And I did a paper with Dave Catterick, and we looked at the national statistics for death rate due to pulmonary embolism, and we estimated that there are at least 940 less deaths per year because this system is in place. So thank you very much for listening. I think for those of us who live in England, we are very lucky because we have a system in place. I'm very proud that Lifeblood was a major driver for this change. I look forward to hearing about what's happening in Wales and Scotland. Thank you.
Thank you very much, Beverly. I'm going to, my job really now is to be Andrew's warm-up man because he's going to be presenting the majority of the work in Wales. But the first thing I'd like to say is that if it wasn't for the excellent work that was being done in England, we wouldn't have made the progress we have in Wales. I remember at the ISTH in Kyoto when there was the first Global VTE Prevention Forum Summit, and there with speakers there from all over the world describing their VTE prevention strategies and what they were doing. And it struck me at the time that I was there as a member of Lifeblood and not representing Wales and the VTE prevention strategy. And the reason was we just weren't doing well enough to even register on the map at the time. Now, the good thing about that is if you really want to get things motivated in Wales, what you do is you tell them that England's doing it better. And so, as a representative of Lifeblood, I arranged meetings with various members of the Health and Social Care Committee, including Professor Mark Drayford, the chair, and pretty much said, you know, it's embarrassing how rubbish we are compared to England. And, you know, we need to be doing better, and in the least we need to have a one-day inquiry into where the problems lie. And he agreed to that, as did the other assembly members cross-party. And we had a one-day inquiry into VTE prevention where we set out our stall and we had experts from all different aspects of the healthcare profession. If ever you have a chance, go online on the Welsh Government website, because parts of it are quite gobsmacking, some of the approaches that certain specialties had. But as a result of that, there was a very clear and cogent message that went through to the Welsh Government, and what they agreed was they wanted hospital-acquired thrombosis prevention to be a priority in Welsh healthcare. What has happened since is through the 1,000 Lives Plus campaign, we have been tasked with trying to improve how VTE is prevented using risk assessment, appropriate thromboprophylaxis, but also every health board is required now on a monthly basis to give figures for the number of hospital-acquired thromboses that they have in their area. And those numbers are then subjected to root cause analysis, and a report is required to go off to the Welsh Government demonstrating what learning activities have happened from that. So each health board will have a system by which the hospital-acquired thromboses are then fed back to the clinicians involved. They'll do the root cause analysis. Learning will happen from those people whose specialties it is. The other thing that's happening, therefore, is we've developed a system in Wales by which our radiology reports are cross-referenced with our hospital inpatient stay, so that you're able to produce an outline of all the hospital-acquired thromboses that have occurred. So you're actually getting true data. When people say some of the numbers that Anna has kind of quoted to you, they say, well, we don't believe them. Actually, when you are having true cases, you're able to actually see the numbers prospectively as we go along. That's very powerful data. The other thing that we've been required to do, because patient empowerment is the way forward. You can't walk onto a ward in Wales without someone challenging you, have you washed your hands? I'm worried about MRSA. And to empower patients to ask about their VTE risk, to actually challenge health professionals about that, is very powerful indeed. So Andrew's just going to present a little bit about the Ask About Clots campaign.
Thank you, Simon. And just to start off with, we've been delighted within Wales to be supporting the First World Thrombosis Day. We've got a number of events planned. We've had staff at Cardiff Wales Airport this morning encouraging passengers as they get on flights to be aware of the risks around hospital-acquired thrombosis. We've got clinical teams meeting in some of our largest health organisations today looking at this very particular focus. So thank you. So picking up where Simon left off, 2012 was the year of the one-day inquiry. There were a number of recommendations that came out from that inquiry, but the one that challenged and was set before the 1,000 Lives programme within NHS Wales was actually to develop a campaign that would engage patients, the public and clinicians around the whole aspect of hospital-acquired thrombosis. We've certainly found within 1,000 Lives is Wales' national quality improvement programme that, working with colleagues on a range of clinical areas and pieces of work to improve, that actually communications provides a real underpinning support to actually tell the story, create the energy around change, and also to maintain the momentum behind it as well. And that was some of the thinking that we wanted to bring, certainly to the work that was going on in Wales around hospital-acquired thrombosis. So this was the challenge, and on the 3rd of April this year, we launched Ask About Clots. And in a sentence, Ask About Clots is encouraging individuals to ask healthcare professionals about their risk of developing a thrombosis so that they can be assessed and provided the appropriate treatment to safeguard them from developing a thrombosis. And that's where we started with the campaign. But we recognised that there were a number of challenges as we started to pull in the campaign together, and potentially a number of barriers. I don't think Simon will mind if I said that our clinical colleagues came to us and said, we want to do a hospital-acquired thrombosis campaign. There you go, you can call it HAT, and you're away with a campaign. And yet actually we needed to find language that would engage the public much more easily. So we looked at actually what would be the most appropriate language to engage the public. We were grateful to have the support of Lifeblood, of Simon as Medical Director for Lifeblood in Wales. We also used a company called Barrett that actually worked with us on public engagement. What would the public understand about the messages that we were putting out there? And that we came up with Ask About Clots because not only was it the title, but it became the call to action that we were inviting, as Simon mentioned in his opening, we were inviting a conversation that in much the same way as hand hygiene, that there's now greater permission for patients and the public to engage with healthcare professionals. That's what we wanted to start creating around hospital-acquired thrombosis. Secondly, we were also aware of the perception, and in terms of the perception of where people thought they were more likely to develop a thrombosis. We surveyed a selection of the Welsh public, and as you see on the screen, 62% came back telling us, well, of course, you'll develop one much more probably on a long-haul flight. That almost set the bar for us in terms of actually what's the perception that we need to change. How do we actually tell the story around hospital-acquired thrombosis as opposed to air travel? And then in terms of responsibility, co-production is one of the big words in Wales, but it's going beyond Wales, I'm sure. But that whole focus of not doing to the patient, but actually working with the patient. And then actually in terms of the conversations that we wanted to see new conversations where patients are being challenging healthcare professionals and asking those questions around thrombosis. So those were some of the challenges that we met. And in terms of pulling Ask About Clots together, we also felt that it was really important in terms of actually how we designed the campaign. Not only what it looked like, but where the focus was going to be. We put a lot of patient stories together on the website, recognising that it is patient stories that are much more likely to engage often than sometimes clinicians, and those stories have been very powerful. We've also been aware as well in looking to try to target a digital market that actually what's the imagery, what are the infographics, what are the details that we need to share through it. And certainly in terms of the strategy, we had a four-pronged strategy that we are taking forward at the moment with the campaign. The first one was a national media launch on the 3rd of April. How do we get Wales talking about it? How do we get people engaged? And we had very good, in a sense, media take-up, local and national press to start the ball rolling with it. Secondly, it was looking at what are the particular at-risk groups in terms of hospital-acquired thrombosis, and actually how do you specifically target those and engage them in new ways. Thirdly, how do we work through NHS Wales internal communications? We employ, it varies anywhere between 80 and 90,000 staff within NHS Wales. How do we make them champions and advocates for this message? And also in terms of digital engagement, what's the story that we tell? So in terms of the launch, Simon mentioned Mark Drakeford. In those intervening years, he became the Minister for Health and Social Services in Wales and has given incredibly strong support to this focus on hospital-acquired thrombosis and prevention. We've told the story through patient stories about one lady who'd lost her daughter to a thrombosis, who's actually been incredibly powerful in supporting the campaign and building that connection. And we've also looked at how we actually introduce the brand to connect people with it. You'll notice that the brand is bilingual, that from a Welsh and English perspective, that we need to be fully communicating in both languages. And then in terms of the at-risk groups, we were very aware, working with Simon and Lifeblood, we identified a number of groups that were at particular risk of developing a hospital-acquired thrombosis. And what we've tried to do is develop messages for each of those groups and go out to those key organisations. So we were very aware that in terms of older people, that was a particular area. We've used celebrities within Welsh media to talk about thrombosis. We're looking to collect. with third sector organisations around these groups. Similarly, with those receiving cancer treatment, that we're working with cancer charities and our specialised cancer hospital in Wales. So again, in terms of with any campaign, it's not just about generating something to initially put out there, but actually how do you take that message forward and connect it more with people to have its impact. As I said, one of the major things that we've been looking at is how we work through our NHS Wales organisations. We've produced educational material. We've produced a communications pack to help organisations tell the story with their staff. So that pack will include template material, template blog lines, template social media material that can actually tell the story. This particular image that you've seen, that's one of many infographics that we've created. Every time we share this on social media, it gets its highest share rate. So again, it's about using the tools, the material, the images to connect. We've worked with events planning. So our largest health board this afternoon are meeting in Wrexham to support their prevention work using these campaign materials. And clearly we're linking this not as a sideline, but linking it into the ongoing work that's happening through NHS Wales organisations. We've also produced a video that I'm going to play to you in a moment, that we are slowly getting into GP surgeries, into health board and hospital, and onto health board and hospital plasma screens to encourage people to ask about clots.
Ask about clots. Ask your doctor, nurse, or health professional about clots. What is a clot? A clot is a blockage in a blood vessel. This can travel to other places in the body. You can have a clot, a deep vein thrombosis, or a pulmonary embolism. Who could get clots? Anyone can. In Wales, 1,250 people are at risk of death each year from blood clots. 66% of clots happen when in hospital or in the 90 days following a visit. Ask about clots if you're an older person. 1% of people aged 80 plus develop clots. If you're having surgery, 25% of people who have serious surgery can get clots. If you are pregnant, pregnant women have a bigger risk of developing a blood clot. If you're overweight, overweight people have a 200% higher chance than other people of developing a clot. You can be a little overweight or very overweight. If you're receiving treatment for cancer, illness and poor health increases the risk of a clot. Because blood clots can be avoided, ask to be assessed for your risk. Anyone can get a clot. You have a higher chance of getting a clot in hospital than on an aeroplane. So everyone should ask about clots. Ask about clots. Ask your doctor, nurse, or health professional about clots. Visit www.askaboutclots.co.uk or Twitter #AskAboutClots.
So that's one of the videos that we've produced in terms of actually telling the story, engaging clinicians, the public, the patients to ask those questions. And then that final focus in terms of our strategy was around digital engagement. Actually, how do we engage with people and the public online? So we used a thunderclap to launch the campaign on the 3rd of April, got a sizable amount of people engaged in it, connected with it. We've been using something called Own the Moment, which is something that Twitter has developed. And actually what we've been looking at is what are the hashtags on Twitter that people that are perhaps interested in health might be following and connecting with. So we've dropped tweets into the hashtag for casualty, Holby City. What are the other programs that people would connect? I think we did something for the semi-finals at one point. But again, trying to look at innovative ways to engage people through social media. We've done targeted blog posts. So our Chief Medical Officer, people from the Royal Pharmaceutical Society in Wales have blogged on their own blogs about why this campaign is so important. We've generated quite a lot of video material, so that actually we know now that the second biggest search engine is YouTube. So actually we need to be putting video on there to actually explain to people why they need to ask about clots. And then finally, those infographics that I mentioned, every time we share something like that on social media, we get an incredibly powerful uptake. Even last night, we had a member of the public engage with us on Twitter saying, I really didn't realise where the risks were. So finding new ways to actually engage and encourage people to ask about clots. So thank you for the opportunity to present to you today. We've got a leaflet telling you a little bit more about the campaign, and certainly if you'd like more details about it, please do get in touch. Thank you.
Thank you very much, Andrew. And moving on, I would like to introduce Dr. Chris Foster from Scotland, who's going to outline the Scottish strategy.
Thanks. Thanks very much. So, yeah, I'm Chris Foster. I'm all the way down from Scotland, which remains a part of the UK, thankfully. I'm day-to-day a jobbing acute and high dependency consultant, but as of earlier this year, I've taken on the mantle of the national lead for VTE in Scotland with my background in quality improvement. So, I think we're not as far on in a lot of ways, but we don't know the way to prevent clot in Scotland. However, we have heard a lot of lessons, and I thought we might discuss the things that we've found today so far, including some of the more sociological reasons why our programs are successful and why they're not, on a recent piece of work that we've done over the past couple of years. So I'm not going to talk through this because obviously we all have the same aims: to deliver risk assessment, to deliver appropriate thromboprophylaxis, to deliver reliable reassessment, and of course to keep patients informed of their care. So what were we going to do? Initially in 2012, before my time, 95% of patients were to be admitted to acute hospitals having appropriate risk assessment and thromboprophylaxis by December 14. That's not going to happen, and that was realised late last year. And so the timeline has been reset. So now by 2014's timeline, the next couple of years, we'll have a sustained improvement in the delivery of risk assessment and thromboprophylaxis at 90% or above in applicable wards by December 2015. And by applicable wards, I mean all acute hospital wards. So this was our new timeline. We're through March 14, we're through June 14. So we have had our preparatory efforts. On an up note, that was essentially already done, so that made it a lot easier. We have got reporting in 22 wards throughout all the health boards in Scotland now, and we've got improvement in one ward in a lot of hospitals. The next thing to move on to is sustained improvement in one ward and spread, and of course you can see the rest of the timeline there. We don't have sequence in Scotland. The approach that we've taken is more quality improvement based, or Deming cycle based approach to the evolution of our program. So, does this have a laser pointer on it? Yes. No. Yes. So this is a growth structure of our program. Is that working up there? So these are really learning sessions. We have learning sessions 3 times a year or so. And supporting this throughout the year, we have expert clinical faculty. We take various visits to different sites throughout Scotland. Everyone assesses themselves and has their own data collection programs in place. We use the internet for web access and listservs, to allow the cross-pollination of ideas that have been found in one place to work to get to other places, and that's maybe just putting on documentation that people have made in their own units, or protocols, or just good ideas. And again, the monthly reporting goes up on the web. We kind of see the journey as an evolutionary one, sort of more a survival of the fittest approach, if you would do. And units really do their own PDSA cycles to find out where that works for them. As a national body, we provide what we need them to do and why we need them to do it. But it's up to each individual unit to work out the how in their unit, because we recognise that all units are different. So this is really the quality improvement approach, and I'm sure everybody here is familiar with the conference room approach of developing a new guideline. Let's say it's one for, I don't know, pneumothorax, and so we design something, and then design, everyone loves it, and it's going to happen as of Monday. It'll just start straight away. But that doesn't happen in the real world, as I'm sure everybody's aware. In the real world, what we move with is this PDSA cycles. So starting, give an idea, let's start a clinician or a pharmacist or a nurse or a patient thinks an idea is a good thing to do. Try it out. If it works, it works. And if it doesn't, then we stop aiming our efforts there and move on to the next idea. This is just something that my colleague said, actually, when I was writing this presentation in my office. This is my office mate. And I thought it's a very good way to sum up our philosophy, is that our way is not the way, it's just our way. So what we have accomplished so far, we've established VTE prevention for all acute admissions as a safety priority with all the boards in Scotland. We've tested processes in every board, and we've got reporting of data from 22 hospitals. The initial data some years ago was the uptake and reliability at that point of risk assessment was 20%, and now it's 70% or so. We've engaged with leaders, we've engaged with clinicians, and we've engaged with clinical governance and improvement teams. We've cross-fertilised ideas and supported learning, and we've learned some sociological lessons for success. This is just the one data slide that I've got, and I think what it does show, I mean, it's maybe not been a huge increase over that time period, but what you do notice is that there's now less variation, and that's represented because we have so many more units engaged and sampling, so we have higher numerators and denominators. So I thought what might be quite interesting to go into was some sociological lessons that we've learned through a group called the Sapphire Group. I will not be able to tell you what it stands for because I can never remember, but nonetheless, it's through the University of the West of Scotland and the University of Leicester. And they use ethnographic surveys and sociological methodology to look at the more psychological aspects. And if anyone is familiar with Deming's theory of profound knowledge, I'm sure you know that the psychology and changing mindsets is the most difficult thing that we have to do in creating any system that works. So the format here was 2 ethnographic surveys. The first one was carried out in spring 2013 across 6 hospital sites. And the second one, 3 of those sites were revisited the following year. It was carried out with interviews from staff of consultants, nurses, managers, junior staff, you name it, they spoke to it. 40 or so different interviews throughout the period, and 232 hours of observational study, taking into account daytime hours and out of hours. In the first study period, that's the different varying sites that were visited. As you can see, there's emergency departments in there. The reason they're in there is because this is the part of the sepsis and VTE collaborative. So this was, we had sepsis work alongside the VTE work. More bang for your buck, I suppose. On one site, unfortunately, there was no work progressing, and it transpires that was because the person who was supposed to be leading it had 3 months put aside for their patient safety fellowship to do VTE, and then as soon as they'd finished that, there was no funding and nobody took it on. Unfortunately, on a revisit in autumn, the consultant who was then taking on that program didn't want to be interviewed. But it did demonstrate that actually programs where there was no senior clinical leadership did not do well, and that's a lesson that we learned throughout this process. So our findings on the initial survey was that there was work progressing in 5 sites. As I say, there was stagnation in the 6th site, and as I say, the follow-up visit in autumn, there was no progress. Regarding prophylaxis, it was noted that prior to the collaborative work, there had been a degree of thromboprophylaxis in place. And that's a good thing. But, of course, it was inconsistent, and it was dependent on what area you were in. That might be dependent on what hospital you were in, but also depending on what type of ward you were in, and what consultant you were under within those individual wards. So it was a very inconsistent process. Some units had moved away already from relying on staff just thinking, oh, maybe I should thromboprophylax, because that doesn't work, and some people had moved away to forced functioning. The differing approaches that they've used for them was, say, putting stickers in cardexes, which had a prescription for low molecular weight heparin on them. Or some units had pre-printed cardexes that already had the prescription in, and it was more of an opt-out than an opt-in situation. As the sort of default position being an opt-in. Surgical and oncological units tended to have a high profile for people being aware of thromboprophylaxis. And this, it seems, was reflected because there was a clear line of responsibility there. I wish I'd printed out all the quotes that I have, but certainly they were finding that surgeons could be investigated should somebody post-op have a PE and they had not thromboprophylaxed. So there was a clear line of responsibility. And there was a coupling of adverse outcomes with doing or not doing something. My other half is a surgeon, and we were talking about this yesterday, and what she was saying is, realistically, what they do in surgery is they take healthy people and put them into an unhealthy situation. If someone has a blood clot after that, it's very obvious, and there seems to be a direct correlation. Whereas junior doctors were think, well, if somebody is lying in hospital in a medical ward for 2 weeks, well, they could have been doing that at home, so they might have got a clot anyway, and there's not really that direct coupling of cause and effect. So the other thing that we saw in medicine is there was no clear line of accountability. And really, what we found throughout this is that an accountability of people actually doing this, I mean, it doesn't really matter who it is, but as long as someone is accountable, is something that promotes a more effective program. If failing to provide prophylaxis was non-consequential, it really wasn't prioritized. And one junior from a regional service did comment that because the consultants didn't really come in very often, because they were often away visiting other hospitals, you know, the juniors tended to get a bit lazy on ward rounds and didn't really assess thromboprophylaxis. So there really was, it was critical that it was a routine and there was consultant buy-in. In some pilot sites, it was already part of the Clarkin process, be this by a single yes or no tick box, but of course that has the obvious disadvantage that you don't know whether or not it's being done correctly when it is ticked. There was no decision aids, and we found that the most effective decision aids were those that were integrated into either the drug chart, or if I use Cardex, by the way, that's a drug chart up north, so if anyone doesn't know that term, that's what it means. So there was no, and the places where there was a separate decision aid, say, being referred to on a wall, people didn't know where it was, or thought there might have been a new one that was being produced, and as it turned out, it was right behind their head. On an up note, all sites were implementing risk assessment tools to support the process, and it was noted that design was really important for engagement. Some risk assessment tools were hugely complicated, they were not nice to look at, and that disengaged the staff and made it far more difficult for them to do their job. We noted there was a lot of practicalities that needed to be appreciated. One site already had a 65-page admission document for various assessments that needed to be made for every patient who came in. New forms were being added daily. Forms that were added separately were at risk of being lost. Pre-stickered systems, it seemed, worked best, but the question is, who does the pre-stickering? There was issues with logistics. Perhaps people couldn't get their forms printed out, and when units were under pressure, things tended to fall apart. We have for example, my unit's got 400 people coming through per week, and we may have just one JHO at the front door and one SHO, and things do fall by the wayside. But in all these units, an element of accountability was noted as positive. Again, reassessment, I don't know what your experience down south is with that, but we find it very difficult, if not just because a lot of these units that were looked at were medical assessment units and acute medical admission units who tend to transfer their patients out within 48 hours, which has the obvious downside that it makes it very difficult to assess and record whether or not it's actually being done. And it also means that we can't test various interventions because the patients are not there to test. Cardex prompts were effective. Stickers in separate forms, again, could be overlooked. Nursing involvement was seen to play a positive role where it was allowed, but the workload that the nurses already had, it didn't allow them to reliably be able to intervene and tell juniors, you need to reassess this, you need to reassess that. And so it seems the ward round checklists and a structured ward round are going to be a way forward that's going to make this a routine on every downstream ward. And again, accountability, I mentioned, was with senior staff involvement was important. So I think with awareness engagement, we're seeing the same themes throughout. A lack of senior leadership was involved, it reflected low levels of engagement. Nurses were a positive role. Safety briefs were something that engaged staff, having everyone meeting up first thing in the morning to talk about safety issues in those wards. COTI bundles, peripheral venous cannulation bundles, central venous catheterization bundles, VTE, sepsis, deteriorating patient. It keeps it in the mindset of the juniors. And we see that just education on its own didn't work. It needed to be reinforced daily. Again, the decoupled outcomes were a problem with engagement and data ownership and availability, i.e. allowing people to collect their own data and work with their own data, promoted units that did that to have better outcomes. So to summarize that part, our learning was that we've had some movement forward, changing the mindsets on risk assessment and thrombo prophylaxis, and making it habitual and easy is the key. Part of a Clarkin document or part of a prescription sheet seems to be the best way to go about it. Consultant leadership is critical and has a huge, huge effect in galvanizing the junior staff. Demonstrated when places didn't have consultants were involved, there was nothing moving forward. Junior doctors need to be involved and can help, not just with their audits. Structured ward rounds and safety briefings seem to be the way forward for downstream reassessment, and education, as I say, was vital but insufficient. Now, round two, don't worry, it's a lot shorter, I'm just about done. 3 sites were revisited to assess sustainability and spread. Essentially, senior involvement reflected the units that had kept the process sustained. The units where the senior involvement had died a death, so had their programme, and so had the effectiveness of their programme. The risk assessment tool, actually a guide within the documents for the end operators, and by that I mean generally the junior doctors, was something that made for reliable and good thromboprophylaxis decision making. There needed to be caution with intervention, so this represents the need for looking at balancing measures, and there was pre-printed cardexes in some units. They really had the most positive role for reassessment downstream. Discussion with patients, informing patients, unfortunately, was challenging in all sites, and I think no one's really found a way further forward with that. So where are we going to have to go? We need to sustain and spread the areas of good practice. We need to allow autonomy and disseminate the knowledge and practicalities of things that we have found to work, both in theory and in practice. A national outcome measure is under development, but it's challenging. We need a lot more senior clinician engagement. We've got some, but not enough. And we need to address the challenges of public and patient awareness. But the best, I must say, I really like the Welsh model, so hopefully we'll be able to appropriate that. Thank you very much.
Thank you very much, Chris. You can probably tell that of all people, I'm the last one in the room who would want to postpone lunch. And so what I'm going to suggest is that if you have any questions or comments, perhaps we can have them over lunch. The other thing is that there are so many excellent activities that are being put on. The stocking-a-thon. At first I thought that was stockings and thong, and that's why I wanted to move on, but no worries. Lifeblood stand, sign up for Lifeblood Buddies, charity yours, and ask about clots. So can I just thank all our speakers and chairs from this morning, and look forward to seeing you after lunch. Thank you.